Welcome to this explainer. We've got a seriously intense debate erupting right now in the healthcare world, and honestly, it affects pretty much all of us. It's a massive clash between health insurance companies and hospital authorities. And the crazy part? It's over something that sounds totally straightforward, a fever. But as you'll see, it's actually incredibly complex. It's this classic showdown between systemic management and frontline bedside care.
So, let's just dive right into it. Think about this for a second. When you're sick, who actually decides if you are sick enough to get a hospital bed? Is it the doctor standing right in front of you, taking your vitals, looking at your symptoms? Or is it the health insurance provider looking at cost efficiency algorithms from a corporate office miles away? Well, that is the exact tension we're unpacking today.
Okay, to really understand this problem, we've got to look at the inciting incident. This whole dispute kicked off because of a recent advisory issued by insurers. Now, what does that mean? Basically, it's a strict set of guidelines targeting exactly how fevers are handled at the hospital admission desk. Insurers essentially laid out a framework to regulate, or in some cases completely limit, when a patient showing up with just a fever should actually be given a hospital bed. Insurers push for systemic efficiency. Let's take a look at exactly why insurance companies felt they had to issue these guidelines in the first place.
Insurers are managing this massive, incredibly expensive healthcare apparatus, right? So their primary goal here is systemic efficiency. Hospital beds are finite, and they are really expensive resources. By rolling out these cost control measures, insurers are trying to prevent medically unnecessary hospital stays. They also want to mitigate potential admission fraud, basically ensuring beds aren't just being taken up by minor ailments. From a macro standpoint, standardizing this care is their way of keeping premiums and system-wide costs manageable for all of us.
But here's where it gets fascinating. We are looking at two entirely different paradigms clashing head-on. On one side, you've got the insurer's criteria. That's a macroscopic model built heavily on objective guidelines and cost efficiency. But on the other side, you have the hospital's criteria. Their model is totally microscopic, built on individualized clinical judgment and the autonomy of the actual physician. It's literally two completely distinct philosophies for how to treat a patient who walks in with a high temperature.
Hospitals reject the guidelines. Because, when these standardized rules for fever admissions dropped, hospitals didn't just quietly accept them.
Actually, they pushed back hard. The hospitals came back with a crucial clinical argument. A simple checklist absolutely cannot replace a doctor's real-time assessment and bedside intuition. Think about it. A fever isn't a disease itself, right? It's a symptom. It could just be a run-of-the-mill virus, sure, but it could also be a blaring alarm for a fast-moving, potentially fatal infection. So hospitals argue that true patient safety requires giving doctors the total freedom to admit someone based on their clinical instinct, especially if they feel like something worse might be developing.
And that brings us to the core of the hospital's identity in this whole dispute. They view themselves as the ultimate defenders of clinical autonomy. They are drawing a hard line in the sand. They firmly believe that medical decisions, especially decisions about who is vulnerable enough to need round-the-clock observation, must absolutely remain in the hands of medical professionals. They just don't think it should be dictated by the economic parameters of insurance adjusters.
So what does this look like in practice? Well, this ideological clash creates a totally frustrating real-world stalemate. Picture this. A patient walks into the ER feeling absolutely terrible, spiking a high fever. The attending doctor assesses their risk profile and says, yep, we need to admit you immediately. But then the insurer reviews that request against their new advisory guidelines, and they challenge or even deny the admission just because the patient doesn't check their specific standardized boxes.
Which brings us to the human element of all this, with insurers trying to empty beds for systemic efficiency and hospitals trying to fill them for clinical safety. The patient is caught squarely in the middle of this massive bureaucratic tug-of-war. Imagine being sick, feeling completely vulnerable, and looking for help, only to find yourself suspended in this awful state of anxiety while two huge institutions argue over the financial and medical validity of your symptoms. It causes real delays in care, huge administrative headaches, and just immense stress for a person who really only needs to heal.
So, as we wrap up this explainer, I want to leave you with a provocative question. Where exactly is the line drawn between necessary healthcare economics and vital patient safety? Both sides definitely have valid arguments rooted in their own responsibilities, but as this fever admission dispute clearly shows, finding a middle ground is incredibly tough. It's definitely something to consider the next time you or a loved one seeks medical care. In our modern healthcare system, who should truly hold the power over your health? Thanks for joining me for this explainer. I'll see you next time.